So I'm a non-voting member, but I would just say having case studies available for transfusion reactions is very important. The most common transfusion reactions are what? We'll do the Socratic thing. What are the most common transfusion reactions? Febrile and allergic, 1 to 2%, maybe a little bit more. The most common serious transfusion reactions are pulmonary, right? And that's why having TACO and or TRALI as case studies is incredibly important. Dr. Flora, who seems like a pretty smart guy, wasn't that familiar with TACO. I can tell you a lot of physicians are not. They're not familiar with TRALI either, and many nurses aren't. What happens is we see it a lot, but it's just, well, the patient was just sick. It just happens that way. The important thing, as I'll get into in my case study, which I go through pretty quickly, is there's two parts of this. The first part is, stop the transfusion, support them, reduce any further harm. But the second part is there is a duty. It's not just a suggestion, a duty to report the reaction to the blood bank, because some reactions could be perpetuated in other donors. So, for example, it could be donor-related. Some donors are more susceptible, their blood is more susceptible to cause inflammatory reactions, allergic reactions, things like that, and those people need to be removed from the blood supply. So we'll talk about that. So again, I'll go through this next section pretty quickly. Who has OB hemorrhage protocols, by the way? We'll get into that in a little bit. So the big thing for OB hemorrhage protocols, the California Maternal Quality Collaborative came up with this brilliant 4 R's of OB hemorrhage. It's readiness, recognition, response, and reporting. So I've kind of stole from that. So when we think about transfusion reactions, we should probably include readiness. That's part of the training, but you could put that into sort of reaction response. You have to recognize it to begin with. So next slide, please. So again, all three of these are important, and the big thing, I know we've got both medical technologists and nurses. Nurses, especially if you give a personal story like Stacie did, is this is why I'm into transfusion safety, because it happened to my stepdad. They're very, very cognizant once they understand the recognition and response part. Again, they get it. Where they're not as supportive is the reporting. And I'll tell you a case study, which some of you may have heard before, which to me kind of cements it. It's not just recognition and response, it's reporting as well. All of these, I would argue, are equally important. Next slide, please. So this, I'm going to put this article, it was one of the most recent ones that I could find that was actually a very, very good review, kind of top to bottom review of transfusion reactions. Actually, I'm going to ask Marguerite if she'll share it. I think smarter than, there's, this is kind of signs and symptoms. Typically when you look at either a nursing or a blood bank document, it'll talk about febrile and allergic reactions, it'll talk about pulmonary reactions. I think thinking symptomatic is smarter, right? Thinking symptomatically is what a nurse would first look for. And as I said, I don't care if it's TACO or TRALI, they're having a pulmonary issue, I need to recognize and respond to it. So again, if she has, let's see if she can share it, something that's more symptom-based to walk around with nurses, these are the symptoms to look for. It's more important to recognize symptoms, stop the transfusion, and then let the blood bank sort it out as to which one of these it is as well. On this particular slide, and I'll include this, the only reason I did this is, here's the practical problem with transfusion reactions. Patients in the hospital generally aren't healthy, right? They have coexisting diseases. Although it sounds pretty easy to say, well, let's quickly pick out transfusion reactions, lots of times they get built into the background noise, which is their condition. So I'm just pointing out here, giving a lot of leeway to the nurses, is that it's not quite as easy as you might think to pick up a fever or a pulmonary reaction, because a lot of this stuff is going on anyway. So at least we need to acknowledge for nursing, it's not an easy job, but you do need to be the lifeguards, you do need to be vigilant and watching for these things, because many of these sorts of symptoms could be attributed to the underlying condition. Where I'm going to go with this is, the safest thing to do is, if you can't sort it out, stop the transfusion, right? If you're not sure if it's the patient or the blood product, if you stop the transfusion, that gives us some time to sort out what's going on, because sometimes it's not clear. Now I'll just pat myself on the back for a half a second here. I'm an anesthesiologist. It's even harder when the patient is asleep, because the patient can't tell me they're itching or they're having symptoms. And in fact, I've never seen this, but one of the classic stories I've heard for transfusion reactions is patients will say something along the lines of, "What did you do to me? What's going on?" That they don't know, they can't describe their symptoms, but something horrible is going on, and they will say, "I'm going to die." And so if your patient ever says, "I'm going to die," obviously you should listen to that. That probably is that cytokine reaction that's kicking off, or maybe it's they're starting to drown. Again, Stacie, we're going to get to the whole lifeguard analogy is really good. So I was a Navy flyer. My son is a Navy flyer now. One of the things that the rescue swimmers would do when you're doing your Navy training is they could spot somebody in trouble before they got in trouble. So you don't have to wait for somebody to go down. You can look at people's eyes and their responses and the panic. That's what Stacie's talking about. Before they actually tip over into TRALI, they're probably telling you something. Now, part of this is you need to be at the bedside, right? You need to be at the bedside for that first 15 minutes observing the patient, but understand even after that, they can still go south up to 6 hours, for example, for TRALI. So again, I just want to point out this. I'll include the reference. We definitely need to talk to our nurses about being vigilant, but we also need to be empathetic. It's not all that easy sometimes, because there are other things that could certainly account for their symptoms. Next slide, please. On this particular slide, the only thing I was pointing out here is acute hemolytic transfusion reaction. That is, wrong patient, wrong unit of blood, and it's incompatible. The incidence, at least, of transfusion reactions that are incompatible is about 1 in maybe 50 to 70,000. That number is a little bit deceiving. The actual incidence of wrong patient, wrong unit of blood is about 1 in 16,000. So what's the gap between 1 in 16,000 wrong patient, wrong unit of blood and hemolytic transfusion reactions of 1 in 70,000? What's the gap there? Maybe it's too late in the afternoon.
The blood types might be compatible.
There you go. Who was that? You get a star. Janice?
Janice at Macomb.
You hit it, Janice. The issue is sometimes we get lucky, or the patient gets lucky, that it's a near miss. That just by the grace of God, we gave the wrong unit of blood and it was compatible. And I have seen that. The problem, however, and this goes back to my aviation, safety roots, is you need to treat a near miss as seriously as if it was an actual hit. And that's a problem. So we get excited about this if it's incompatible, but if it was compatible, the temptation anyway is, no harm, no foul. Not true. We just got lucky. So the incidence of hemolytic transfusion reactions is about 1/4 of actual wrong transfusions. We just got lucky because the units were compatible. So Janice, you get the TSO of the day. This is what I was pointing out. Simple allergic reactions, absolutely. The single most common transfusion reaction is allergic or febrile. Much higher incidence in patients that have gotten blood before. So these are our cardiac surgery patients. For the folks from Carmanos, these are cancer patients. Very concerning, but again, we need to break out the background scatter. Is this a relatively simple reaction or not? One of the side issues, and we might talk about this when we get into transfusion order sets, is some doctors think you should pre-medicate everybody, right? The temptation is, well, because some patients get allergic reactions or febrile reactions, let's just give everybody Benadryl. Let's give everybody Tylenol. So Melissa, you're shaking your head. Why is that the wrong thing to do? You're gonna mask it, right? So that's different. So if you give everybody Tylenol or Benadryl, you simply take out some of those early signs of a major transfusion reaction. And by the way, Erwin can probably cite the articles. Benadryl has a much higher reaction rate than transfusions do. Transfusions is 1% to 2%. Benadryl, 1 in 3 people feel kind of squirrely when they get it. So then you start to get into, is this pharmacy or not? So absolutely, in people who are not at high risk of transfusion reactions, you should not pre-medicate. That's different from, again, cancer patients. Every time Mrs. Smith comes in, she always get a febrile reaction. We've documented in the laboratory information system that she always does. We try to do, type specific or wash cells, but she still might need some pre-medication. That's a completely different animal. So that's an important point. And one of the things we're working on for the transfusion order sets is not putting pre-medication orders right next to transfusion orders, because if that happens, what do doctors think? Oh, I should give Benadryl, I should give steroids as well. Erwin, I assume you agree?
Absolutely.
Next, please. And then just one thing to remind us, just to be complete, there are delayed transfusion reactions. So we've talked about even pulmonary reactions. It could be 6 hours, so you have to be vigilant. There are also transfusion reactions that happen when they go home, right? So it could be a week later, they start to get jaundice and things like that. These are delayed hemolytic reactions that also should probably be on discharge paperwork when we send patients home as well. For those of you that transfuse a lot of outpatients, cancer patients, we should make sure that we also are giving them instructions on what are downstream reactions that could show up as well that may not show up in the hospital as well. Next slide, please. So again, I'll show you just a couple. This is data that we did at SHG, which then sets up the case study. We did chart reviews. We did a lot of chart reviews over the years. And what our nurses were doing, that included Marguerite, was looking at random samples of charts that got transfusions and seeing if they saw a transfusion reaction. Not surprisingly, our nurses would find a lot of transfusion reactions based upon vital signs changes that were not reported either by nursing or by the blood bank. So the bottom line, maybe skip ahead 2 slides, 1 slide, 2 slides. So what we found, and this was, we did at least an abstract, on this, is based upon this, we found that only 59% of the time, 60% of the time, nurses actually recognize transfusion reactions. So about half the time they weren't recognizing them. And when they did recognize them, they typically just reported to the attending physician. This is the disturbing stat, is only about 1 in 5 actually reported them to the blood bank. And I think this is one of the challenges with blood management programs. Really good TSOs in a lot of health systems, very much like Stacie and Marguerite, they get the why. I'm doing this because I love it, I'm interested in it. And it's relatively easy to get nurses vigilant at the bedside, looking for transfusion reactions, especially for good case studies, and saying, it's a transfusion reaction, I'll call my attending. The last mile that's extraordinarily hard to close is report it to the blood bank. And I think this is one of the issues that we see in McLaren is the reported rate of transfusion reactions stays very, very low. I think nurses are picking them up at the bedside. They're just not closing the loop and getting it to the blood bank. The case study that I'll now get into that some of you may have heard, I think is the single best case study I've ever seen for this is why we report transfusion reactions. So next slide, Pat. So Jessica Rose, who's heard this story?
I actually
All right.
posted this out to all of
Yeah.
my physicians at
Okay.
the hospital.
So for half of you, the other half of you, so Jessica Rose. So next slide, please. So Jessica was, that's the key word here, 6-year-old kid down in Tampa that had a neuroblastoma, had gone through, I think, a 2-year protocol for chemotherapy. Can't imagine, right? Can't imagine what that would be like to a parent to go through this. Was at the very end of her chemotherapy, in fact, was recovering from chemotherapy. And the story, and this is the story told by the mom, this is sort of public record, was that the oncologist recommended kind of one last platelet transfusion, probably because the platelet count was a little bit low. And again, remember, this is the end of chemotherapy. It's not the beginning or the induction or again, I'm inferring from this that it was a prophylactic transfusion, meaning that there's no history that I got from the mom or anybody else that the kid was actively bleeding, having purpura, but the number was low, the oncologist was uncomfortable and ordered platelets. Another part of the story that's important, it's even worse if you listen to the mom tell the story, is she had gone to every single treatment, chemotherapy, infusion therapy, blood product this kid had ever had, but end of therapy, was really busy, grandma, and it will just take the kid to the oncology clinic with the transfusion. Next. So Jessica Rose goes in for a top-off transfusion. As soon as the transfusion, or shortly after the transfusion was started, had a very severe transfusion reaction. Fever, chills, became hypotensive. They actually called an ambulance. The kid was actually air-evac, as I understand it, to a pediatric hospital. That's how severe the reaction was early on. Went to the PICU, eventually died 3 days later of multi-system organ failure. So again, goes in for a routine transfusion, has a severe transfusion reaction, and is dead 3 days later. So next slide. Question here is what's the most likely scenario in this kid getting platelets? Hemolytic transfusion reaction, severe allergic reaction, transfusion transmitted bacteria, or Zika? C. I shouldn't put C. It's always C, right? So yeah, the answer here is bacterial contamination. I'll go into this. But again, just kind of like the TACO thing, you put this in front of nurses, I would bet you 6 ways to Sunday, bacteria never even enters in the picture. Well, bacteria, we're concerned about HIV, we're concerned about hepatitis, bacteria, are you kidding me? So next slide. So again, you know this, but I'm illustrating this as a case study that can really educate your nurses. Why bacteria, and why platelets? So the difference in platelets as opposed to other blood products is platelets are kind of funny animals, and they don't like being frozen and they don't like being refrigerated. So we can refrigerate blood products for 42 days, red cells. We can freeze plasma, but platelets, the FDA does not allow us to do anything to them other than store them at room temperature. The problem is, how do we get platelets? Well, we stick people in the arm, we go through the skin, and as compulsive as techs are, some bacteria can still come through that poke, even with diversion pouches and all these other things, and one single bacteria that sits in a culture medium at room temperature for 5 days can become a big, big problem. So again, this is an illustrative point. People don't even know. Why are platelets different? Well, they're stored at room temperature. Oh, I didn't know that. We can only store them for 5 days? Yeah. Well, bacteria are also the problem in platelets because they are stored at room temperature, so a single poke can do it. The other thing, and again, no diss against blood bankers or the American Red Cross, is which blood product do we give our patients? Do we give it the freshest unit or the oldest unit? We give the oldest unit. So we're going to give not a 2-day platelet, we're going to give a 4.5-day platelet because they're the last one on the shelf. And understand, every day those bacteria multiply and grow and grow and grow. So again, believe it or not, 1 in 3,000, 1 in 2,000, and 1 in 3,000 platelet transfusions contain bacteria, often unrecognized, and can certainly cause bacterial sepsis. Does it happen all the time? Yeah, probably. I don't know if I've given 3,000 platelet transfusions, but I've given a lot. But again, many patients either have comorbid conditions, so we don't pick up the fevers and the chills that they're getting are from the platelets and not something else, or that again, they can sort of shrug it off, so to speak. So very, very common, but under-recognized and underreported, and relatively unique to platelet transfusions as well. So what do we do about this? So what the blood industry did because of this, they said, well, we're going to quarantine platelets for 2 days, and we'll test it at 2 days to make sure there's no bacteria. Then we'll release it to the transfusion unit. So one of the problems is now we only get 3 days to give platelets, right, because they're quarantined for 2 days. And the other thing is bacterial sensitivity is not 100%. So although we might catch a couple of 2 days, we don't catch all of them, so we're going to get some leakage, and that's why this 1 in 3,000 isn't up there. So here's where it gets really interesting / sad. So they actually looked at, after Jessica Rose got this transfusion, and they had a seg, and they pulled it and said, well, it's bacterially contaminated. Well, they said, well, let's look at the donor record, and it turns out that the donor who gave Jessica Rose those platelets had actually given platelets to another patient as well, and it's not uncommon. So platelets are typically done by apheresis, typically males, because we're bigger, have more blood volume. It's not unusual in apheresis to get actually 2 units of platelets, 2 6-pack of platelets. So next slide. So it turns out that donor that gave Jessica Rose those bacterial contaminated units had given another unit that was given to another child the day prior at the same infusion center. That child, however, got a day fresher units of platelets, so it probably wasn't as contaminated, and happened to be a 17-year-old boy, nearly a man, so did get severe chills, did get a transfusion reaction. They recognized it, they stopped it, they treated him symptomatically. However, they did not report that unit transfusion reaction to the blood bank. So somebody connect the dots for me. What happened here? What is one of the reasons that Jessica Rose died?
The first unit was not reported to the Red Cross, so they could recall the second unit.
There you go. So this was, so it may be she didn't need the transfusion. It may be that the nurse wasn't as vigilant at the bedside because Jessica had been there, 50 times, and it's just Jessica and she's just fine. Maybe the nurse was busy. Maybe they gave it too fast and they didn't recognize it soon enough. Because I go through the scenarios as, what if they caught it early and they stopped the transfusion? Maybe it was a survivable dose, right? And the difference in a non-survivable and a survivable dose could have been 20 cc's, 30 cc's, maybe a couple of minutes, one way or the other. This is probably the most egregious thing that happened, is that at the same donor center, at the same blood bank, they recognized a severe transfusion reaction in another patient. They stopped the transfusion, treated that child appropriately, but failed in their duty. And it's a duty. This isn't a suggestion. This is a regulatory requirement to report it to the blood bank. This, to me, is the connection for nursing on, this isn't just the blood bank being, sticklers and they want us to do a lot of paperwork, blah, blah, blah. This is the reason we do it. The reason that we require not just to treat the transfusion reaction, but to report it to the blood bank and the donor center is because there may be other units or donors out there that are susceptible or can cause multiple transfusion reactions. So to me, this is the single worst/best case that I could give to nurses on why it's not just recognition and response to transfusions, but we also have a duty and an obligation to report, because this child is dead because they did not report the transfusion reaction. Had they reported the transfusion reaction, that blood bank would have done what? They would have pulled that unit off the shelf, they would investigate it, and they would have never issued it. And she'd be here today. Next slide. So this, to me, is kind of the single most thing of everything that Stacie said and I said, is the most important thing for nursing is if you suspect a transfusion reaction, stop the freaking transfusion. Stop the exposure of the unit. You buy time to sort it out. If it turns out the doctor wants to evaluate it and say, oh, Mrs. Smith always gets febrile reactions, and under his or her direction wants you to continue it, you've done your duty. But you need to stop the transfusion if you suspect it. Don't know about Jessica Rose, but I kind of run that math and say, if they stopped it 2 minutes earlier, 5 minutes earlier, maybe it would have been survivable, you never know. So stop the transfusion. If you even suspect it, stop the transfusion. You will never be, or you should never be faulted for doing that. After that, your second responsibility is you need to work it up as a possible reaction. And the first thing you do at the bedside is, the most common cause of severe transfusion reactions is the wrong patient got the unit of blood. So you do a bedside check as the unit is stopped to say, did we somehow make a mistake at the bedside? And if not, then you call the blood bank. What Stacie said is incredibly important. You do not need a physician's order to stop a transfusion. You do not need a physician's order. If you suspect a transfusion reaction, you stop it immediately to reduce exposure of a potentially hazardous unit. You also do not need a physician's order to report it to the blood bank, who then the pathologist takes care of the workup to be able to do that. Those points, I think, are the most important points to get to your nursing. The importance of stopping the transfusion to reduce exposure. And if you called it wrong, so what? So if it's not a transfusion reaction and you restart it under supervision, you did the right thing. You did the right thing. On the other hand, if you do not stop it, you don't listen to that, voice in the back of your head, you have the potential of something catastrophic happening.